Hello and welcome to the Electronic Visit Verification public meeting. We'll go through a few housekeeping items. Please, all phone lines are muted. Questions should be submitted through the chat feature. We will not be answering submitted questions during today's presentation. Questions will be addressed after the presentation through a listserv communication. Please reference the slide number if applicable when you submit your question. This is our agenda for the day. We'll start with Office of Medical Assistance Program updates. You can move on. For OMAP fee-for-service training, all OMAP fee-for-service providers intending to use the DHS SAMData EVV system must receive training from the DHS SAMData EVV system. Training will be done using a train the trainer model. Trainers can attend either a live webinar or a self-guided online training course. Providers may enroll for the training webinar beginning August 10th, 2020 at the following link. The webinar will be conducted on August 28th, 2020. Providers may do self-paced training if they're able to attend the webinar available at the following link. Further information regarding training sessions will be sent to providers via a listserv mail. MA bulletins have been prepared for OMAP providers and are currently undergoing executive review. Issuance is anticipated to occur mid-August for fee-for-service providers. Fee-for-service providers are expected to be using either the DHS EVV system or the alternate EVV system of their choosing no later than September 1st, 2020. PCS claims with a date of service on and after September 1st, 2020 through December 31st, 2020 will be matched to information in PROMIS and compared against information in the EVV aggregator. If the information does not match, error status code 927 or 928 will post and have a pay and list disposition. Claims still will pay during this time period. But beginning dates of service on or after January 1st, 2021, claims posting error status code 927 or 928 will post and have a denied disposition. PCS claims, personal care service claims, for PHMCOs with a date of service on and after November 1st, 2020 will be matched to information in PROMIS and compared to information in the EVV aggregator. If the information does not match, error status code 927 or 928 will post and have a pay and list disposition. Encounters will still pay at this time. Beginning with dates of service on or after January 1, 2021, the above referenced physical health MCO encounters posting error status code 927 or 928 will post and have a denied disposition. And I'll introduce you to the Office of Long-Term Living updates.
Thank you, Ellie. This is Kristen Weierman from the Office of Long-Term Living. So for OLTL providers, all OLTL providers, as a reminder, who are providing personal care services are subject to the EVV requirements. For claims that contain personal care services with dates of service on or after January 1st, 2021, there must be an EVV record in the DHS aggregator for claims that are submitted through PROMIS in order for those claims to pay. So personal care service claims without matching EVV data will post error status codes of 927 or 928 in a denial disposition at that time. Currently, if you are submitting claims to PROMIS for either the Act 150 or the OBRA program, those EVV error status codes are populating, but they are in a pay and list status. So right now, it's really important to be monitoring those error status codes to ensure that if you are seeing a 927 or 928 error, you're learning and adapting your system to make sure that that isn't occurring in the future when payment would be denied. our hope for the rest of the soft launch period is that providers can become acclimated enough to where they're not seeing significant financial impacts whenever these error service codes switch to a denied disposition. For the CHC managed care organizations in community health choices, they will also be verifying EVV data as part of their claims adjudication process. Next slide, please. So as we mentioned, OLTL strongly encourages providers to be capturing EVV visits now. The soft launch period where providers were really learning about the systems and implementing the systems really has come to pass. This is the point in the implementation where providers should really be using the systems regularly, making sure their staff are remembering to use the system for shifts, making sure they understand how to correct visits if data is incorrect, and then ensuring that claims are processing appropriately with the matching EVV data. In addition to that, providers also need to ensure that they are sending DHS or data to the DHS aggregator for fee-for-service programs, including Act 150 and OBRA, or to the CHCMCO system called HHA Exchange. Next slide, please. So just as a quick reminder, because I know with OLTL, one of the most complicated portions of our implementation is that we have two different systems. We have our managed care community health choices system, and then we have our fee-for-service legacy system with the OBRA and Act 150 waivers. And many providers still operate in both. So it's important to remember that if you are operating in both, you need to take steps to implement EVV in both programs. So for community health choices, providers serving participants must implement an EVV system, follow all implementation directions provided by the managed care organizations that you are contracted with, send EVV visit data to the managed care organizations, and you do have the option in CHC to either utilize your own chosen EVV system or the HHA Exchange system operated by the managed care organizations. However, the DHS SAN-Data EVV system is not available for community health choices. That system is specifically built for the fee-for-service program to send data directly to the aggregator and match claims in Promise. And in CHC, since you are no longer billing Promise and you are billing the managed care organizations, the data must go to the managed care organizations, either through their system, HHA, or your own system that you integrate to send data to the managed care organization. And as one last reminder, if you do have your own EVV system and you are sending data to HHA Exchange and the managed care organizations, you do not need to complete the aggregator training or the alternate EVV certification process operated by SAN-Data. Next slide, please. And then for fee-for-service providers, any OLTL providers that are still serving participants in the OBRA waiver or Act 150 program must also implement EVV for these programs. And your options for doing that are either completing training and using the DHS EVV SAN-Data system, integrating your alternate EVV system with the DHS aggregator in order to send data to the aggregator, and then that aggregator will match the EVV data to Promise claims, or you can work with HHA Exchange, if applicable, to send data for fee-for-service programs such as OBRA and Act 150. But that is not an automatic process just because you're working with HHA Exchange in community health choices. Providers must confirm with HHA Exchange that this process is complete if that is the choice you are making to implement EVV for fee-for-service programs. Next slide, please. All right, and with that, I will pass it off to the Office of Developmental Programs. I think Jen Grimm, are you unmuted? Bear with us 1 second. It looks like we are experiencing technical difficulties. Chuck, are you unmuted?
Hi, Kristen. I think I'm unmuted now. Thank you.
Oh, yep, we hear you. Thank you.
All right, great. All right, slide 16. Again, my name is Chuck Frick. I'm with the Office of Developmental Programs. We're going to cover the ODP updates. As all ODP providers who render personal care service are subject to EVV. I think hasn't changed at all. I just want to reiterate what Kristen said with the 927 and 928 error status codes. It's very important that you start remediating those now to understand. So as we get closer to January 1st, 2021, we don't have any claims denied. So again, providers should all be actively working on the 927, 928 error status codes. Next slide, please. Okay, ODP strongly encourages providers who are not already capturing EV the visits electronically to do so now and ensure those visits are being sent and stored in the DHS aggregator. As a minimum, providers should be fairly close or capturing the visits now. We understand some providers might have issues with putting the data into the aggregator, but you should be collecting the visits. Providers already capturing visits should ensure they understand the meaning of any EVV edits, so that are sending and understanding what corrections are needed to take place. So this again goes back to the 927 and 928s, especially we need to get those edits, and providers need to understand how to remediate those edits. Next slide, please. Agency with choice. Agency with choice are required to comply with all departmental requirements as condition of participation in the medical assistance program. SSPs and managing employers are required to participate in the department's required EVV process. With the agency with choice, we did have a meeting. I just want to make sure everyone's aware that anyone who uses the agency with choice has to participate. It's not so if the agency with choice says they need the information for the SSP to implement EVV, that you have to supply that information to participate. So we expect all SSPs to work with their managing employers and with the agency with choice to make sure EVV goes without a hitch. Next slide, please. All right, this just kind of reinforces what we said. Earlier on, we did put out a memo to AWC to make sure they felt comfortable that this was part of the requirements that they can enforce. So I guess we heard earlier on that some managing employers and SSPs maybe not wanting to participate in the agency with choice model, or we're not supplying the information. This just kind of reinforces the agency with choice's responsibilities. So again, the individual or circuit as the managing employer of the qualified SSP is responsible to verify time worked by qualified SSPs and improve timesheets. This includes participation in the EVV process. Agency with choice therefore have the authority to require SSP participation in the EVV process as a condition of employment. So, yeah, so we hope this clears up any miscommunication or that might be going on out in the field. So if you have any questions, please contact, if the agency with choice has any questions, they should be contacting their administrative entity, their AE, about any implementations or any issues they may have. We also have regional representatives that are very versed in most agency with choice within the ODP program, know who their regional lead is. And if you have any more issues, I would also suggest that you contact them as well. Next slide, please. All right. Yeah, effective Monday, coming this Monday, PALCO will be rolling out their EVV system. We hope that all SSPs are signed up and we really, this is just a plug that you need to get. If you haven't signed up with PALCA, that you need to supply your email address and supply them with the information that you need so they can successfully implement the EVV program. So if you have any questions on how to do that, obviously the registration forms and materials are on the PALCA website. So you can download them, send them in, make sure you're signed up. But it's imperative that all SSPs sign up and that we get going. So August 16th is, we're going to start capturing the visits. We need to make sure we have 100% compliance. So obviously, if you're not enrolled with PALCA at this time, then we expect the CLE and common law employer to follow up with the SSP that they have on staff to make sure that they enroll with the EVV program or with PALCA. So again, please, if you have not signed up, download the materials and send the registration into PALCA so we can make sure you're going to get paid timely as well. So if you don't do the EVV system, you're still submitting paper timesheets, or it might not be capturing and your payment could be delayed. So it's very important that SSPs sign up with the EVV system. Next slide, please. Okay, EVV implementation updates and reminders. Next slide, please. All right.
Yes. So, I'll pick this up. Yep. So we're going to start with a few general implementation reminders and then some updates on our implementation progress. And then we'll move into specific information about the SAN data system as well as the alt EVV certification process. And then our last section will be frequently asked questions we received from the last public meeting. So kicking off with some of the general reminders, as I know most of you are aware, we are implementing EVV as part of the 21st Century Cures Act, and we must implement for personal care services as of January 1st, 2021, based on the good faith effort exemption we received from the Centers for Medicaid and Medicare Services. After that, we will quickly begin moving forward with the implementation for home health care services, which will be required January 1st of 2023. Next slide. And just as another general reminder, the Cures Act does require the following 6 elements to be included and captured during a visit. Next slide. So the implementation of EVV does not impact the provision of personal care services. And this is important because we receive a lot of questions about whether or not participants can continue to receive services in the community and whether workers can clock out somewhere outside of the home, and they absolutely can. The nature of personal care services in the home and in the community is that these are services that are supporting our participants throughout their daily lives, and their daily lives are not restricted to their home. So EVV systems should be flexible in allowing workers to capture their time if they need to clock in or out outside of the home based on a participant's service plan needs and their daily activities. Next slide, please. So the location of service when delivered is required and must be submitted as part of the EVV visit data. So the location needs to be collected at the time of clock in and clock out for any given shift. GPS is one way to capture the location of any visit, but it is not the required technology to log that location. As long as an EVV system has a mechanism where it can gather the location at the time of clock in and clock out, that is absolutely fine, but the location does need to be captured. Next slide, please. So EVV validations are not performed against the specific location of service when the data is evaluated in the aggregator for claims processing. So although we require the capturing of services, claims are not going to be denied purely based on the location logged by the EVV system. The claim also has a place of service code that has to be included, and that was a standard as part of the claims processing long before EVV. So during normal claims processing, the place of service code on the claim detail line is validated to ensure the location in which the service was rendered is permissible as specified in the waiver. But this will not include the location logged on the visit. Because this validation occurs normally during claims processing, there will be, as I mentioned, no validation in the EVV aggregator record. Next slide, please. So for telephony visit verification, so this is when a provider is using a phone to call in to clock out of service. So this isn't using a smartphone application or something along those lines on a tablet or anything like that. This is specifically typically using a landline or a fixed VoIP device. But telephony visit verification is acceptable. And cell phones can be used, so a basic cell phone could be used in conjunction with a location device, but there must be some sort of capturing of the location when calling in with telephony. So if the cell phone is accompanied by some sort of location device that generates a code, that is absolutely fine. Or if telephony is used in conjunction with a landline and that landline is registered to an address, that is absolutely fine. But the location does need to be captured when using telephony. So you can't just use a basic cell phone to make that call because there is no mechanism to capture the location by itself. Another device would need to be included. And there are quite a few different options for how EVV vendors have chosen to approach that. So you might want to explore the different options available depending on the EVV vendor that you're working with. Next slide, please. So EVV visit data requirements. The technical specification and addendum documents that the department has released and that are included on our DHS EVV website are a requirement of the EVV implementation. Please refer to the website to view the most current EVV addendum. The reason that these are required is because DHS must be able to aggregate all data submitted for EVV by all entities by aligning those data elements. So required fields that are outlined in these documents are required to implement EVV for all providers in all programs. Entering false data in any of the required fields is not compliant for EVV implementation. For example, the last 5 digits of the direct care worker's social security number is a required field in order for us to be able to uniquely identify workers. And this must be submitted for each individual providing care. Next slide. As a quick reminder, this is just a chart showing kind of the feedback loop for our open model system. So you can see CHC and the managed care EVV system, they feed into the aggregator, and then the SAN data system also feeds into the aggregator. And you have our fiscal employer agents and our alternate EVV systems for those in fee-for-service. All of these systems feed into the DHS aggregator and then compare with either claims or managed care encounters submitted through Promise. And that's really important because we have received a lot of questions lately about how fee-for-service providers send their EVV data to Promise. And you're not going to be sending it directly. You'll need to work with SAN data to complete that aggregator implementation so that the aggregator can compare the data to Promise. Next slide. So providers currently submitting EVV data either through the DHS SAN data EVV system or their own alternate EVV system need to verify the error service codes that we were referencing earlier. And this is going to be important as we move into the next couple of slides. We're going to touch on the details of those error service codes and then also the data that we're seeing as of this month for progress in meeting those requirements. So if you need to reference those error service codes and you don't currently have the document, it is posted on the EVV DHS website. And that document is extremely helpful. I encourage everyone to download that because it's going to give you the different error service codes that are specific to electronic visit verification, and then it's going to tell you what they mean, and then there's going to be the last column that shows you what, if any, action you need to take. Not all error service codes require for you to make any corrections or take action, but some do, and those are the most important ones to pay attention to, and we'll get into those in a second. Next slide. So as you can see here, these are the error service codes that we have been referencing, and we really want to draw your attention to the service codes we have highlighted in orange. So 927 and 928 are the two most important error service codes that you want to pay attention to. These other error service codes, they are informational edits, but they do not require any action by a provider or an agency. So 927 and 928 are the two codes that right now in the soft launch period are information for providers to understand that if we were in full compliance, these claims would deny. So it's really important to look at these now and make sure that any corrections are made either to how your staff and your office, your administrative staff and your direct care workers are using EVV, and any issues with getting your EVV data to the aggregator, because otherwise these claims would deny. And if you receive these two error status codes, you would have to review and make corrections when necessary and resubmit the claim once we are in a denial status on January 1st. So the more preparation that can be done here to really understand the requirements, the better prepared and the less impact providers will see on January 1st. Next slide. Next slide, please. And you know, as you've heard us repeat many times about the error status codes, the reason we're bringing this up is because we are monitoring the current progress of EVV visit data as it compares to claims, because to us this is a really great measuring stick for what impact EVV would have on providers if we switch that disposition to deny today. So for example, you can see in the Office of Long-Term Living program, we're really only seeing around 3% of EVV or of claims supported with proper EVV visits. And this does fluctuate a little bit month to month, but we're really not seeing a rate much higher than 5% right now. And that's part of why, as we mentioned earlier today, the denial disposition will remain the denial disposition will be delayed until January 1st rather than the previous date of October 1st. We really don't want to see providers be negatively impacted and disrupted, especially with everything else that you have going on right now and the demands, particularly with COVID. So we really want to make sure everyone's successful and give you as much time as possible so there isn't any negative impact. For the Office of Developmental Programs, we're seeing a bit higher of a rate, so they're up around 15%. So that's definitely improving. There's still a good bit of work that needs to be done there as well. And then for Community Health Choices, we're seeing around 55%. So we're still working to get that up closer to the high 90s or 100. Next slide, please. Okay, so to validate if your visits are verified or need corrections, you'll need to either check the system that you're using. So there's a couple different scenarios here depending on the system you're using. So for any alternate EVV system users in the fee-for-service program, you'll need to check the aggregator to make sure that your visits are being appropriately captured in the aggregator from your own system and are in a verified status. They must be in a verified status, and we'll show you here in a minute what that will look like in the aggregator. For SANdata users, you will check your SANdata system for that activity. And then for HHA Exchange users, you'll need to validate visits and make sure if any corrections need to be made that you're working with the MCOs and HHA Exchange to understand how their system is configured and what requirements they have for full verification of visits. Okay, next slide. So as I mentioned, if you're working in the DHS aggregator, if you see down here circled in orange, this is where the visit status is going to show. So right here, these show as incomplete. So although the visit was submitted to the aggregator from this EVV system, it's incomplete, so it is not going to support any sort of claim. It would bounce back as no visit found until this visit was corrected and verified. Next slide, please. So it is recommended that all DHS aggregator users refresh themselves every once in a while on the DHS SAN Learn aggregator course. So, you know, recommended would be something like every 6 months as you're learning about EVV and the new systems and acclimating your staff, just to make sure that as you're moving along in the process, you're getting refreshed on anything you might have forgotten or functionality that may make the process in your office a bit easier and more streamlined. And the course is only 30 minutes in length. Next slide. Okay, and with that, I think I will pass it, I think it's Chuck that'll take over alternate EVV certification.
Yes, Kristen, thank you. Next slide, please. This is just some statistics here. So alternate EVV system, currently testing, we have 46 alternate EVV systems with testing completed. We have 26. I seem like I said that number twice, 46 and 26. Apologize if I repeated myself. Alternate EVV systems in receipt of production credentials, 118. Alternate EVV systems with confirmed data in the DHS aggregator, 61. And alternate EVV providers still needing to contact SAN data to confirm data. So next slide, please. Any providers intending to use an alternate EVV system other than the HHK exchange for fee-for-service should have already begun the testing process. Providers starting this process now run the risk of not being able to meet the January 1st, 2020 claims denial deadline. Really, providers should, should have started this process a while ago. So hopefully you're not waiting till the last minute, because it does take a little while to get through the process steps and to test and everything like that. So if you're starting now, you need to be due diligent and get things started right away. Again, it is the provider's responsibility to follow up with their vendors throughout the entire certification process. So yes, so again, if you're contracting with a vendor, it's all EVV vendor, it's your, as a provider agency, you need to make sure they're on task and they're communicating with SAN data and to make sure they're up and running. All right, next slide, please. Okay, here's a list of the following alternate EVV vendors who have completed the certification process with SAN data. So we have ClearCare, Direct Care Innovations, eSystem, Horizon Information, JulieSoft, Kaleidoscope, Kichi Code, Matrix Care, MITC, Post EVV, and you can see the others as well. I'm not going to read each one of them, but these are the ones that completed certification. Next slide, please. All right, hopefully this chart is well ingrained in everybody. Obviously, these are the 8 steps that you need to get through to all the EVV testing and certification process. I would hope most providers are, at least step 6, 7, and 8 right now. When talking to providers myself, it seems like most providers are around step 7. But again, as our earlier slide suggested, if you haven't started, it could, it takes a little while to get to through the process. Next slide, please. All right. Do you have all EVV production credentials? Yes. Did you complete all the steps? As noted previously, only half of the 118 agencies with production credentials have completed all 8 steps. you are expected to confirm your data is flowing correctly in the DHS aggregator with the PA Alt EV support team. So it's not just enough just to collect the data in your EVV system. You have to make sure that it gets to the DHS aggregator as well. If you have not sent an email confirming your live data isn't it, do not wait any longer. So please confirm that you're sending data. As we get closer to January 1st, 2021, DHS expects support call volumes to increase. This could affect your claims if you wait too long to confirm data and have any issues. So it's imperative that we give this extra time, that we use it wisely, and that we're looking at our error status code, we're looking at our data, and that things are going smoothly. Because again, we do not want to wait till January 1st to try to start resolving any problems. Next slide, please. Skipping any step in the certification process runs the risk of EVV data not being compliant and claims being denied starting January 1st. Don't assume anything. Validate every EVV visit so you aren't receiving claims rejection charges. So again, it's up to the provider and the vendors to be proactive and to make sure that their system is running smoothly. All right, next slide, please. Again, fee-for-service providers utilizing an alt EVV other than HHA exchange systems need to contact Sandata alternate EV support team to be certified and integrate with the DHS aggregator. So here's the information. I think this is just a combination of all the slides we just talked about, that it's how important for you to contact Sandata. And there's the information right there. The certification process takes approximately 8 to 12 weeks, depending on the testing requirements. Again, it's not overnight. So if you're waiting to start this process, you need to start it now. So it's going to take a couple months, to get through it. The process can only depend on whether an alt EVV vendor is new to the process and provider responsive. Please note, due to many agencies waiting until July to start testing, some steps may take longer due to increased volumes of requests. So, 8 to 12 weeks is a guideline, but it could be longer depending on how many providers are trying to get through the system. All right, next slide, please. It is important to monitor your email and spam folders. So we do get a lot of, that your system might think an email from Sandata is a spam. So just make sure you check that every once in a while to make sure you're receiving your emails or any correspondence. A quick reference guide for alternate EVV certification outlines the steps of the processes and the expectation for Xandr providers in alt EVV. The quick reference guide for alternate EVV certification is available on the DHS website. So really the DHS website, we'll go through this later on, is one of your great resources, but all provider agency and vendors really need to be knowledgeable about the DHS website and make sure they go to that site for all their information. Next slide, please. When contacting the Sandata or EV support team, detailed setup information is required, including what systems are used to collect the EVD data. Missing information may lead to additional delays. It's really important when you're contacting the team here that you have all your information, that you have your ticket number, if you have a ticket number, what's the problem, so who, what, when, where. Those questions you should be asking, because the less information you give to the team, the more research they have to do, and that just delays everything. So the more information you can provide up front when you have a ticket or you're following up on a ticket, the better for everybody involved. So make sure you have all your information available, and so there's not any delays in trying to get your certification or get the issue resolved that you have. So again, here's the technical team, the phone number and their email address. Next slide. Again, for ultimate system report, as Rick did, completed visits should be sent in real time. So alternate EVV completed visit data should be uploaded to the DHS aggregator. Upload frequency should be set based on a provider service volume at a frequency of no more than once a day. It's expected that information is sent as it is, added, changed, deleted in the alt EVV system. Redirection responses will be delivered on a separate API call that is initiated by the third party in near real time. So you're going to, you understand what those rejections are. Next slide, please. All right. So we're going to go into the DH Sandata EVV system. Okay. The DHS Sandata EVV system is live. The system is free and available for use by fee-for-service providers, ODP, OLTL, and OMAP. If fee-for-service providers are intending to use the system, they must take the online training and receive a welcome kit, which will provide their access to the system. Next slide, please. If you are a fee-for-service provider and have completed a training but have not received a welcome kit for your agency, please contact PAC at 1-800-248-2152, or you have the email address there. Reminder to check your spam, junk folder for welcome kit or login credentials. If the welcome kit expired, call the PAC to get a welcome kit reset. And there's the information right there. Okay, next one. DHS Sandata EVV Learning Management System is a train the model. Agency administrators and supervisors should take the training and then train their respective staff. So this is a very good tool. Providers need to be aware of it, need to make sure they understand as they train their staff and supervisors. It's a very good self-paced online training is available for providers planning to use the DHS EVV system and agency administrators wanting to take a refresher course. So obviously, you can get through training once, but sometimes it needs multiple times to get through it to understand it. So currently we have 662 unique provider agencies who have completed training and received welcome kits to date. So that's a good fair number. So next slide, please. In the recent EVV compliance survey, 79 providers indicated they intended to use the DHS Sandata EVV who had not completed training and received their credentials. See provider systems with no activity who do not complete online self-paced training will be decommissioned in October. So we have a lot of providers who said they were going to use the system, but they're not using the system. So just want to be aware that if you're not going to use the DHS system, maybe a lot of providers that did the survey thought they were in between. They weren't sure if they're going to use the alt EVV system, they're going to use the DHS system. But we need to start nailing that down to where you need to know what system you're using. So these 79 providers will be decommissioned. If you intend to use the DHS Sandata system, please do not wait and use the system. Use it now. So again, just reiterating that you signed up to use it. Please start using it now. Next slide, please. Sandata EVV platform passwords expire every 60 days. So if you're not using the system, you just let it there. Your password is going to expire. You're going to have to ensure you receive a notification to change your password ahead of time to avoid lockout of the administrative account. Please assign more than one person to be security administrator. All new passwords must be unique. Users are unable to reuse any of the past 24 passwords. So it's a very secure system, and so again, as it says here, make sure you have more than one security administrator for the system. Next slide, please. DHS Samdata EVV will change the Samdata Mobile Connect app security lockout functionality to better align with DHS security requirements. So here's some important dates that you have to remember. Effective August 17th, 2020, after 3 unsuccessful login attempts in 15 minutes, a user will be locked out of the Samdata Mobile Connect. It is recommended that upon 2 unsuccessful attempts to log into SMC, users reset their passwords and not make a 3rd attempt to log in, risking getting locked out. So if you did not do successfully 2 times, might not try the 3rd and do what is recommended here in this bullet. Effective August 17, 2020, SMC passwords will be required to be a minimum of 12 characters long. So pretty big password, but I think we're seeing that more and more as we use new systems that have bigger passwords, unique characters and stuff like that as well. SMC users with a shorter password should update their password to be at least 12 characters. We ask all agency security administrators to please inform their respective staff members of this change. All right, next slide, please. Providers should go to the visit maintenance daily, if not regularly, to view all visits and correct any exceptions. Password resets for caregivers should be done by agency supervisors. Caregivers experiencing issues should report them to their supervisors or administrators. Taking your caregivers to provide you specifics will help expedite troubleshoot the issues. So it's an imperative. Obviously, I think password reset is going to be one of the a lot of function of an administrator. So I think you should have an agency protocol set up. So when someone does lock themselves out or passwords expire, that you have a good system in place to get the information you need so these changes can happen quickly and efficiently, and everyone understands the process. Next slide, please. Employee module password reset for SMC. Administrators unsuccessful attempts at supplying temporary passwords for locked SMC users. Please try the following before calling the PAC support. Use the search feature under the employee mobile to query your list of employees. Select a pencil to edit the employee. Deselect the mobile user checkbox found under hire date, then select save and close. Please wait 10 minutes prior to editing the same employee. Wait time is important. Edit the employee using the pencil and reselect mobile user checkbox, then save and close. Wait 10 minutes before executing the temporary password reset. We have all the steps there in line. Again, 10 minutes is very important to wait. Next slide, please. Again, visit maintenance. You should not edit any time unless there is a correction that is necessary. And again, here's your PAC support, your 1-800 number, and your email. So important to have this information as well. Next slide, please. Again, here's what I kind of talking about earlier. In order to assist you, DHS is asking for your help to reach out to the support team. When opening a support ticket, please provide the following information in your ticket. Again, your agency's name, STX number or agency ID, contact phone number, a description of the issue, how or where the issue is occurring, and in what system, the DHS aggregator, the mobile app, etc. Date and times if relevant to the issue, impact level to your agency, and what is your desired outcome. So just kind of follow the steps there, and when you submit your information, make sure you have that information in the ticket. Next slide. Additional helpful suggestions for your support tickets. Be as descriptive as possible about the issue. Again, who, what, when, where. Each agency is different, and issues are not always the same from agency to agency. The more information you provide, the better in helping getting to resolution faster. It is kind of be specific, avoid general terms or generic terms. Always slow, laggy. Sometimes this happens. We are hearing sometimes a screenshot, provide a handsome screenshot whenever possible. This helps the support team to recreate a possible error for troubleshooting purposes. Request a ticket for future follow-up. So again, screenshots are always helpful when I do technical support, and always keep that ticket number, so a reference if you don't hear anything in a certain time frame, you have that ticket number to go back to. Next slide, please. All right, here's a Sandata Help Desk response timeline. It gives you the description and service level. Several issues where a provider cannot operate a core piece of their business due to a defect with no reasonable solution. Example, system down. Initial response within 30 minutes, thereafter every 4 hours until a resolution. I'm sorry. There's some crinkling there on the call. Apologize about that. Issues where provider can continue to operate while impacted by a defect using a viable solution. Example, issues that can be mitigated with the use of a workaround. Again, initial response be one business day, second follow-up next business day, third follow-up every 2 business days. Other issues not described above, example, welcome kit, initial response next business days, second follow-up every day thereafter, third follow-up every 3 days. All right, next slide, please. All right, important deadline to note. Provider agencies, oops, my screen went blank. Provider agencies intending to use the DH Sandata EVV system need to complete EVV training in the LMS no later than December 11th, 2020. Really, you need to get on it quicker than that, but that's no later than. Any agency completing LMS training after December 11th will not be guaranteed that they will receive their welcome kit credentials in time for the January 1st, 2020 deadline. I hope providers are not waiting to this is the absolute minimum here, so all providers should be working on it now. Agency administrators should allow sufficient time after completing the LMS training and receiving the welcome kit to train the rest of their staff and direct care workers. Next slide, please. All right. Frequently asked questions.
Thank you, Chuck.
Yep.
All right, so we'll move into frequently asked questions that we received primarily as a result of the last public meeting. But before we do, I just want to reiterate one major change that we did announce today, so everyone fully understands, because we've been throwing a lot of dates at you throughout this presentation. Previously, when we last met, the expectation for OLTL and ODP was that providers would have claims denying if they did not have appropriate EVV data matching their claims on October 1st, 2020. We did make the decision this week and announced today that that will be delayed until January 1st of 2020. However, the only thing being delayed is the claims switching to a deny status without EVV data. That in no way means that providers should not already be using an EVV system to collect data. So please continue with the process of implementing your system, training your staff, completing all necessary activities to send your data either to your managed care organization or to the DHS aggregator, whatever is most appropriate for what program you are serving, and really monitor those error service codes. So I know there's some confusion around the dates, but we did delay the switch to denying claims until January 1st of 2021. We strongly encourage providers not to ease off of their implementation activities so that you're using fall most appropriately, and you will not see any major financial impacts on January 1st. Okay, so first question. What should we do if we want to use SAN data for our CHC participants, but right now they are in an HHA exchange? So as we mentioned before in the presentation, the DHS SAN data system cannot be used for Community Health Choices participants. Providers who are in Community Health Choices must either use the HHA exchange system offered by the managed care organization or integrate their own external system with HHA exchange. The DHS SAN data system has not been built to send EVV data to HHA exchange. Next slide. So do providers using HHA exchange need to verify data in the DHS aggregator? No. Providers do not need to verify their data in the DHS aggregator if they're using HHA exchange. If you are using your own EVV solution with HHA exchange, then you would need to also integrate your solution with SAN data if you are serving fee-for-service participants. At that point, yes, you would need to use the DHS aggregator. But if you are not serving individuals in the fee-for-service programs, you do not need to use the DHS aggregator. Next slide. If a visit is verified manually in HHA exchange due to a failed clock in or clock out, but is accompanied by documentation, will this be denied? And I'm going to cover a second question here because the answer for both of these is the same. And if a provider is using HHA exchange, how and where can they view any errors? So for all questions that are really in regards to how the HHA exchange system operates, you really need to be working with the CHC MCOs and HHA exchange contacts that you have to understand how their system requires the correction of errors, the correction of exceptions, and proper documentation and manual editing. Every system is unique, and the MCOs have set up the HHA exchange system to operate well beyond just an EVV system. For those of you on CHC, you understand that HHA exchange is a lot more than that, and their system is custom built for their operations. So any questions related to how that system operates needs to be directed to the CHC MCOs and HHA. Next slide. Why does a claim get an EVV error status code 925 if the visit is verified and no changes are needed? So as we mentioned before, as we were going over that chart, this is really just an informational edit to demonstrate that an EVV visit was found and matched as part of the claims adjudication process. There is not any action that you would need to take when this status code appears. Next slide. How do providers fix the problems associated with error status code 927 and 928? So as we've covered before, please refer to the guidance that is on the EVV DHS website that outlines each error status code, what it means, and then the steps that you need to take whenever they populate. Next slide. Is a plan of care or service plan required during the soft launch phase of the EVV implementation? So EVV does not in any way change the expectation of all of these service planning requirements in OLTL and ODP programs. Service plans or plans of care are still required for all ODP waivers and OLTL waivers. A provider should be contacting their support coordinator or service coordinator if there is not a plan of care or service plan. And plan validations continue during the soft launch period. This is really a separate process from EVV. So it's an important thing to remember. EVV is not impacting service plans. Service plans are still your source for understanding what you are authorized to provide. Next slide. If there is a discrepancy between what is authorized and the claim, how should providers handle this? For example, the participant is only authorized for 1 hour of care, but the provider bills for 2 hours of care. So building off of the last slide, the process to address unit discrepancies submitted on a claim versus the units that were authorized on a service plan does not change with EVV. If there are insufficient units authorized on an individual's plan in HCSIS or via the CHCMCOs, compared to the number of units submitted on the claim detail line will either be cut back to the units that were authorized or deny. So EVV does not change the authorization process. You still must follow the authorization requirements for providing services. EVV is simply a source of data to support the claim you are submitting, but it does not override authorization. Next slide. If a caregiver is not following scheduled visit time, how will this affect the agency's billing and authorization? As an example, the participant is authorized to receive 1 hour per day per week, and the caregiver is working past the shift by 1 hour on a consistent basis. So this is really another scenario along the same lines of what we've been addressing. The requirement for DHS or the MCOs to only pay for authorized hours remains in effect. So if a caregiver is continually working over those hours, the provider needs to direct this issue with the caregiver, and if there appears to be an additional need for that participant that is causing that additional time work, contact the service coordinator for additional support. Next slide. If a caregiver clocks in, but there are no units left in the service plan, will the caregiver still be able to clock in and out? And part of the scenario is that sometimes a critical revision due to some sort of trigger event may not yet have been completed. So yes, the EVV system will capture the clock in and clock out times, even if the units are not available at that moment. But once the critical revision is complete and the units are added to HCSIS or to the service plan through the MCOs, the provider agency can then bill the claim. So simply providing the visit and capturing the EVV visit is not enough. You will still need that additional authorization, even though it is going to be coming late. It is also important that the caregiver work with the provider agency to understand what the service and duration is to be provided before beginning the shift. Next slide. So if a caregiver forgets to clock in and then clocks out when they remember, so say they remember about 30 minutes after they got to the participant's home that they forgot to clock in, is it preferred that the caregiver does not clock in late, or should the caregiver clock in late and then have the supervisor edit the time? So along these scenarios, and there's a lot of different ways this could occur. This could occur at clock in, this could occur at clock out. There's any number of scenarios where, for whatever reason, that shift is going to need to be fixed. So it's really up to the providers on how you want to make those corrections. If you want to direct your staff to clock in as soon as they remember and then correct that later, that's fine. But you really need to set up a process within your agency for both your office administrative staff and your direct care workers to have a system for how to address these issues. But ultimately, it will require correction, but how you pursue those corrections is up to you in your daily process. Next slide. How will verification occur if there is a sustained power outage? In this scenario, and this answer really goes for anything. I mean, this could be a scenario where a direct care worker's phone breaks or the battery dies, or there could be any number of scenarios here where, for whatever reason, the EVV system is not accessible for a given period of time. So when that occurs, while a caregiver is clocking in or clocking out, the provider's administrative staff who manage the EVV records can then make a manual edit or entry into the EVV system being used. It is the responsibility of the provider to provide the caregiver with the EVV rules and policies to address emergencies or any sort of situations or events that are outside of the caregiver's control. Next slide. So how many manual edits will be allowed to the visit? So all these different scenarios we just talked about require a manual edit. So whether someone forgot to clock in or their phone broke or the power is out, For whatever reason, all of the scenarios we just talked through require a manual edit to the EVV visit. Manual edit compliance rates will be included in the upcoming bulletins and will be measured on a quarterly basis. So both the Office of Medical Assistance Programs and the Office of Developmental Programs and the Office of Long-Term Living have bulletins that are being released in the very near future, sometime within the next week or two. And they will have those compliance rate expectations for how many visits in any given quarter are acceptable to be manually edited. That being said, that is the bare minimum. And we do understand that, you know, manual edit rates may be a bit higher as direct care workers are getting used to the system. We have established a minimum threshold, but we will be looking to improve those rates over time. So we don't want providers to just look to achieve the bare minimum. We really want to increase the quality of this data integrity as we move forward. So subsequent guidance could be released in the future as we learn lessons and really understand kind of how this all plays out and everyone acclimates to the system. Next slide. Is there a specific time period to make the manual entries or edits for any of the kind of issues that we've just covered? So there are no policy timeframe restrictions from a DHS perspective when it comes to manual adjustments to an EVV record. But it is important that any adjustments that are made to an EVV record accurately reflect the service delivery date and time frame and are resubmitted to the DHS aggregator or to the MCOs if the provider plans on submitting a claim or a claim adjustment or a resubmission of any original claim. So with effective dates of service January 1st, 2021 and forward, it is critical that a matching EVV record is sent and stored before a claim is submitted. So one of the things we are seeing, particularly in Promise, is that claims are being submitted before EVV visits. That is going to, on January 1st, 2021, result in a claim denial. The EVV visit data needs to be in the aggregator to compare to Promise before the claim is submitted in the aggregator, or into Promise. Otherwise, that claim will have to be resubmitted because there was no EVV data present to support it. Next slide. Should EVV still be used for remote services for ODP since the location will not match? Will this be approved and paid after January 1st? So and this is specifically for the Office of Developmental Programs, and from my understanding, this is a special exception right now because of the COVID-19 situation. So as a special exception for this specific scenario for Office of Developmental Programs, caregivers can clock out using EVV in the community regardless of whether the address is in the system. There will be no validation against the location of service found in the DHS aggregator record. Next slide. When the participant has a cell phone as their home phone, is telephony still able to be used with that phone? Yes, a cell phone may be used if there is a way to capture the location at the time of service, such as a fixed verification device. Next slide. When using telephony visit verification, can staff use their personal phones? As an example, some staff do not have a smartphone and the client does not have a cell phone or a landline. So yes, personal cell phones can be used for telephony visit verification if there is a way to capture the location, such as a fixed verification device. And when we say fixed verification device, there's a couple different terms for these, but really the general standard is these are small devices that generate a unique code at the time that you're clocking in or clocking out, and that unique code is entered as part of the visit entry whenever you're calling in to enter that visit through the phone. And it is the provider's responsibility to ensure caregivers have the necessary equipment for EVV, as it is a part of program requirements. Next one. Can providers purchase track phones for participants that do not have a phone for staff use only to be able to call in or call out? Yes, cell phones can be used, as we discussed before, and I know this one specifically referring to the location of service, but there are also, I know, track phones that are smartphones that could operate an app as well. So you still have to follow, if you do purchase a track zone for the participant's home, and we know we know several providers have actually purchased very small tablets for their workers to use, and it remains at the participant's home. But if you purchase any type of device that remains at the participant's home for workers to use, not only do you need the consent of the participant to leave it somewhere in their home that is appropriate, but you also need to make sure it meets all the requirements. So if it is a cell phone, it does need to capture the location. Or if it is a smartphone or a tablet, it needs to be able to operate the mobile application. It is the provider's responsibility, once again, to ensure caregivers have the necessary equipment to provide the services. Next slide. So who should be contacted if participants are missing or being rejected? And this is specifically related to the DHS aggregator and the SANDATA EVV system. So an authorization feed is used to validate alternative EVV records containing valid MCIs. If an individual is missing from the authorization feed, then the alternate EVV record will reject and prevent the record from flowing into the DHS aggregator. To resolve this, confirmation should be made as to whether or not the individual has a plan in HCSIS with an authorized personal care service. If the individual does not and should, then the service plan should be updated and the EVV service record resubmitted. If this step is completed and the issues persist, please contact the PAC line included here. For users of the SANDATA DHS EVV solution, the authorization feed provides the DHS EVV solution with the individual's MCI and the personal care services authorized on the individual's plan. If the individual was missing from the authorization feed, then they may need to enter the direct care worker may enter the individual's name, MCI, and other information into the SANDATA EVV solution. This action would be considered a manual entry. Next slide. So how does EVV work when a staff moves from one service to another? For example, a participant has companion services overnight, but on occasion they need assistance and the service that they are receiving transitions to a habilitation service for part of that shift. So any change in service to the same individual, regardless of whether or not it was delivered consecutively or intermittently, requires a separate clock in and clock out action for each service provided to the same individual. So every service must be recorded separately because every service logged in EVV is matching with those authorizations and the claims. So for example, if the caregiver renders respite from 12 to 12:30 and then in-home and community supports from 12:30 to 1 to the same individual, the caregiver would need to check in and check out for both of those services. Next slide. For day respite service, which date do you want used in promise? The date that the service was started or the date the service ended? There continues to be an error message of visit not verified. So when billing for a day respite service, so this is specifically an Office of Developmental Program service where the unit is a day long. The respite in Office of Long-Term Living Programs is a 15-minute unit, so this would not apply. But when billing for day respite services, the provider should use the date the service started. When billing for day unit services that are rendered overnight and across calendar days, the claim detail line must contain only one date of service. And that date of service is the from date of service, so the date that the service started. Next slide. All right, and we just have our last slide here of EVV contacts for everyone's reference. I know we covered a lot of different information and directed you to a lot of different contacts depending on your specific issue. So you can see all of the different contacts here for any support you need moving forward. All right, and with that, that concludes our updates for today. And as we mentioned, due to the fact that we are all in a remote status right now. We're not going to be answering questions that we received on the call today, but we will take them back and draft a new update message for our listservs here in the coming weeks. And then we'll also include some of those frequently asked questions from the presentation today on our next EVV public meeting. So thank you all for joining us today, and have a great weekend.